Okay, I'm Toni DiChiacchio. I'm a family nurse practitioner here at Chestnut Ridge in Morgantown, and today we're going to just review some recent research findings and the future horizon of best practices in managing buprenorphine discontinuation. Just to set like baseline foundation, I'm not gonna go back and present all research from the beginning of FDA approval of buprenorphine and discontinuation, but just know that there have been clinical trials looking at using this medication as like a detox medicine and detox in residential and tapering off during that stay. Very poor outcomes. Shorter duration has been shown to increase risk for relapse, overdose, and death. But I just, for the past, from 2020 on, we're going to look at some observational studies and then a current randomized control trial that's going on, and then some tools that might be useful. Really, there's very limited evidence on ideal safe discontinuation. There's no equation to use. There are some observational research showing certain characteristics and taper rates and taper methods that may be successful. But there's no great evidence, there's no great guidance, even from manufacturers or professional organizations, on how to do this safely. There is, however, or there can be, a conflicting perspective between us as clinical providers and patient desires. Both research and anecdotal evidence show that patients have a vision in their mind, or a perspective or goal, to someday come off maintenance medication. Vast majority want to do that, and for various reasons. Could be stigma. Stigma has improved of late, but our patients still deal with issues with pharmacy, issues with mutual support groups and being on maintenance medicine, issues with family and friends saying you're not really sober, so that still exists. It also can be costly, particularly if you have a high deductible plan or you have no insurance. Not only do you have to pay for the medication, you have to pay for the visits associated with getting your prescription. There can be concerns for side effects or long-term safety. I hear a lot these days about dental health. I don't know if you guys do, but I hear a lot more about concerns for sublingual medication and their impact on oral health. There can be concern for, and this is a big one. I try to check in at least twice a year. I try to do it like the first of the year and like midsummer with my patients that are in monthly or bi-monthly groups. So sustained sobriety, just what their vision is. And I always preface it like, no pressure. I just want to know where you're landing right now, what your goals are. And invariably, maybe other than like one or two people, they'll say, yeah, I eventually want to discontinue, but I'm not ready now. And then I'll ask, why do you want to discontinue? And invariably people say that they're afraid that someday they're not going to be able to get their prescription, which I can imagine would be very frightening. And then there's also just a desire to be free from physical dependence to anything, and self-perception of what true sobriety is. Now, from our standpoint as clinicians on a treatment team, we know that we want to keep our patients safe and alive. And if they're doing well and they discontinue, there is a risk for return to use. And our illicit drug supply is exceedingly dangerous. And so that causes concern. So shared decision-making is important, but we can sometimes come from this from different perspectives. Whoops, sorry. Again, there's no great recommendations from the professional organizations or even the government or the manufacturer. SAMHSA comes right out and says like people that discontinue are likely to return to illicit use. And the National Quality Forum, I don't know if you're familiar with that, but that's an organization that studies and archives quality measures for like shared savings with insurers, like CMS or commercial insurers. And in 2021, they came up. Now, this isn't encouraging discontinuation at all. As a matter of fact, that the quality measures for addiction treatment is to keep people on longer, but they say a minimum of 6 months for quality measures purposes is best practice. But they admit there's no great data on it either, somewhere between 180 days to 3 years. They didn't even have their scientific. So National Quality Forum they have like committees, and they have like a scientific committee, and they didn't even have their scientific committee, that does analysis of research, randomized control trials, and make sure that the data is robust and the statistics are done appropriately. They didn't even have them look at that for this recommendation because there isn't enough data to really even analyze. So recent research, these are all like observational or qualitative that have gone on in the past 4 years. This is published in 2020, and it was a retrospective cohort analysis using Medicaid patients over a number of states. And that to be included in the analysis, the individual had to be on BUP for at least 180 days, and then subsequently post-discontinuation, still enrolled in Medicaid for 6 months. And basically what it was doing was cohorting these individuals in different lengths of time on buprenorphine, 6 to 9 months, 9 to 12, 12 to 15, 15 to 18, and comparing outcomes and adverse events. And the specific adverse events they were looking at was ED visits, hospitalizations, getting an opioid prescription, or overdosing. And there was a statistically significant lower adverse events when you compared the greater than 15-month group with the 6 to 9-month group. But really across all cohorts, there were adverse events, with 5%, regardless of cohort, having at least one overdose, and nearly half, being seen in the ED at least once. This was interesting because it's a high-risk population. I want to really emphasize this is not the standard of care. This is not the standard of care. It's a dangerous time both for mom and baby to titrate during pregnancy, but some women are interested in that. And this was a clinic that treats specifically pregnant women. And they looked at women that they volunteered to wean. They were really driven to wean. And they compared their outcomes with the control group, standard care. So in total, there were 334 women in this group. 39 decided to wean. And the definition of taper in this study was lowering the dose greater than 20% at baseline. They did not have to discontinue completely. When they started, they both were at very similar dosing. At delivery, the taper group was down to about 4.5 milligrams, and the control group was around 13. The average length, or the average time in pregnancy when the taper started, was just over halfway through, almost 23 weeds. 10 women, or 26%, were successfully able to discontinue prior to delivery. But really, there were some difference in neonatal opioid withdrawal, which would not be unexpected between a higher and a lower dose mom. And birth weights were a bit higher, the percentile birth weights in the lower dose mom versus the higher dose mom. But otherwise, there really was no big difference. There wasn't a difference of age at delivery, or C-section rates, or perinatal visits. No maternal deaths or ODs in either group. But it was just interesting to compare. I do want to emphasize that these women were very closely monitored during their taper, and the relationship continued postpartum. Looking at patient characteristics that an observational study found, looking at specifically overdose post-discontinuation. Again, retrospective cohort study. This is done in Ontario. People were on BUP for at least 60 days, so pretty short period of time, just over 5,700 individuals in the cohort. And what they found was that, and none of this will be surprising to you, but not starting a taper until at least the person has a year of sustained sobriety had lower OD rates. A slower taper was better than a rapid one, and slow was defined as less than 2 milligrams or less per month. And then the number of days between lowering the dose, the wider you made that, the better the outcomes were as far as overdoses post-discontinuation. But even in this group, 66% of the cohort study found that there was either an overdose, a re-entry into treatment, or prescription opioid use within 18 months of discontinuing. This is like a qualitative data mining study. I don't know if anybody gets on Reddit, but there's a Suboxone subreddit forum, and I do lurk in there sometimes because I find it really interesting to see what's really going on in the out there in the real world and what people are doing. And so these authors, they did a thematic analysis of this Reddit forum, and there were nearly 2,000 unique users, over 16,000 posts. And it's really, most of this is people sharing their personal experience. And the top 3 topics were all about Suboxone, advice on using it, how to dose it, and how to taper it. That was a big topic. And in regard to tapering, this analysis showed that individuals share that they have had more success discontinuing when they did a longer taper. And specifically going from 2 milligrams to 0 milligrams is the hardest period of time. And the ones that had the most success spread that 2 milligram to 0 milligram over a 3-month period at least. The most commonly reported adverse events, not surprisingly, that were bothersome, that really were complained about frequently: diarrhea, insomnia, restlessness, and fatigue. And the number 1 recommendation that they had to each other was to exercise. By far, that was the one that, people should exercise. It really helps with withdrawal symptoms, but also clonidine and Imodium. And the tapering strategy most frequently recommended was cutting a 2 milligram film into 32 pieces, and then obviously decreasing over time. I have never recommended that. I find that so interesting. The most common final dose prior to complete taper was 1/32 of a 2 milligram film. So that's 0.063, followed by 1/16 of a 2 milligram film. I'm not even sure that you could be certain that there would be actually medicine in 1/32 of a film, but it really is interesting what people do successfully, and people were able to taper using those methods. So variables associated with sustained sobriety, again, this is not going to be surprising. Stability in life. No one's life is going to be perfectly stable, and we can't promise no one will have stress, but having a job and financial stability and a loving, supportive family, and no CPS cases in the work, no court cases, no risk of incarceration, being off parole, all of those things play a part. Being on a lower maintenance dose when titrating, and of course link of sustained sobriety supported by objective negative drug screens. Treatment team recommendations are important. Shorter duration of illicit opiate use prior to entering treatment is indicative of a lower risk with discontinuation. And then strong social supports and motivation clearly are important. I find it very interesting that if the evidence and both in research and anecdotal are correct, and people really have the goal of discontinuing this, if we could get them to us quicker, within a year of the identification of a physical dependence, we could probably do much better with getting them on it and then eventually taper off. But oftentimes, frequently, we don't see people until they're certainly in moderate to severe opiate use disorder, and it's a lot harder. So some tools. These authors did a really good job. This is it was an article looking at methadone and buprenorphine discontinuation. And what they did was pull all the information that is available in observational studies or just clinical recommendations, expert recommendations, into these kind of checklist for treatment teams to really systematically go through risk factors and mitigating factors. And so they kind of, and you wouldn't have to do it this way, but the way they broke it up was a medical provider section, and then a therapist and patient section where the therapist actually sits down with the patient and goes over some of these things. So on the medical provider side, it's really looking at things like the PDMP and making sure that they're not coming to you asking for more medication than is prescribed, or taking more medication than as you have prescribed if they have comorbid mental illness. If they're also taking benzos or stimulants by prescription, those would put them in a higher risk category. Basically they're using their medicine appropriately and not for things like stress or mood or sleep. And then that they're on a dose, ideally for bupe, 8 milligrams or less. And then for the therapist patient side, it really is looking at recovery capital. And the goal is not only to assess readiness, but also perhaps to allow the patient themselves to gain insight on their personal readiness and maybe things that they can shore up before they complete titration or taper. Things like if they are using other mind-altering substances, how they're coping, if their structure of their life, are they in school or employed, do they have purpose? Are they staying away from triggers? Have they gotten rid of their paraphernalia? Do they have a supportive family? Do they have a spiritual practice? And if you say, yes or no to any of these things, it doesn't negate approaching a titration, but it just gets everybody on the same page and acknowledges the risk factors and maybe identifying some mitigating factors that they could work on. And one of the most important things is, do they themselves want to taper off? Because oftentimes we see, and I'm sure you have too, where there's an external force, whether it's CPS or just judicial system in general or family, saying, you really need to come off this. You've been on it long enough. And that external pressure is not ideal. It really is best if someone has the internal drive and motivation and readiness to discontinue. Other considerations, I think, are really, probably to me, the most important is assuring that there's a lifeline post-taper, whether it's with the medical provider or the therapist or a peer that's associated with the treatment team or the clinic, just some way, if things start going awry, to be able to rapidly re-enter treatment. Tapering suggestions, and we talked about this before, incrementally 2 milligrams or less per month. Once you get down to 4, even slowing that down more, and that you stop with discomfort or risk for relapse. It's not a race. If they're having trouble, even with the 2 milligrams, you can try alternating doses. For example, if they can't get from 8 to 6, maybe every other day, 8, 6, 8, 6, 8, 6, and then doing 6 for a month, and then alternating again, 6, 4, 6, 4, 6, 4, then 4 for a month. There's some reports in the literature about, and I do not have experience with this, and if anybody does at the end, I would like to hear what your thoughts are. But once getting to 4 milligrams or less, to transition to the mono product, to like Subutex, because the theory is that the absorption of naloxone at that dose, at that low dose, can cause some agitation symptoms that could be confused with withdrawal. So that was one recommendation in the literature that I've never tried or never seen done. Obviously, prepare the patient for like the time frame when they may have mild discomfort. Our goal isn't more than minimal or mild discomfort. That's why the slow taper over a long period of time, and certainly providing comfort medicines for them for the most common withdrawal symptoms. And then if a taper is complete successfully, offering naltrexone, Vivitrol post-taper for added protection, and reinforcing that is not a medication that they'd be physically dependent on, but is just there to protect them. Extended release buprenorphine is a new tool. I mean, it's not new. We've had it, but as far as a tool in the toolbox to help with discontinuation, and it makes sense logically when you consider a medication that has like 24 to 48 hour half-life compared to a 30 to 45 day half-life. The noticing withdrawals and cravings would have a much slower onset because of the tail effect. And obviously we're talking about Sublocade and now Brixadi. And there's been a couple case series presented, and I thought that this is limited information. You're not going to get any information in capital recovery for these patients over these these case series, but I thought we could look at them, and I would like, if you would, as we go, there's 7 of them, as we go through them, mark which case you would be most comfortable with discontinuing and least comfortable with discontinuing if they were your patient, and kind of why you feel that way. Okay, case number 1. 51-year-old male, alcohol use disorder, OUD, in sustained remission. He's been on Subutex, 8 milligrams for 6 years. Was doing well, ready to titrate, able to get down to 2 milligrams from 8, but not more than that. His physician, this is a kind of a novel approach, attempted a tramadol plus a butrans or transderm bute patches, and clonidine and lorazepam to help with the withdrawal symptoms during the taper, but that didn't work out well. So the gentleman decided to stay on Subutex for another year, but at half the dose. So he was on 4 milligrams at this point for another year. Got a 100 milligram one-time injection of Subutex and successfully was able to titrate. These first 3 cases, they didn't tell us, the authors didn't say how long at publication that the people have still maintained sobriety. The later cases do, though. So case 1. Case 2. 35-year-old female, alcohol use disorder, sustained remission. It's important to note that this individual did not meet the criteria for opiate use disorder. Regardless, was physically dependent on oxycodone, which was started during her pregnancy for migraines. So was having trouble discontinuing due to physical dependence with withdrawal when she tried to titrate. So she was stable. So she came into a program, was stabilized on 6 milligrams of Subutex, and over a 14-month period went from 6 to 2. At 2 milligrams, she started experiencing life-interfering withdrawal symptoms. It was hard to work and it was hard to take care of her baby once she got down to 2 milligrams. But got just one 100 milligram Subutex shot and was able to discontinue successfully. 46-year-old female, again, did not meet the criteria for opiate use disorder, but has physical dependence on opioids, had been on pain management for 8 years, also has comorbid anxiety and medical trauma. She was stabilized on sublingual bupe, 12 milligrams, stayed on it for a year. After a year, wanted to try to taper and received clonazepam for post-acute withdrawal symptoms, but was unsuccessful with the taper. Unfortunately, this particular patient had to have a mastectomy around this time because of breast cancer and was put back on full opioids for a couple years. Tried over that 2-year period to get off the full agonist, but had a difficult time, so was re-inducted on bupe and started at 20 milligrams, stabilized over time, went from 20 to 6, and then at that point had one 100 milligram Subutex shot and successfully discontinued. Of note, she did about almost a year after her last injection, she did have 3 acute pain episodes requiring full agonist, and was able to take them with a range of 1 week to 4 weeks and successfully discontinue after the acute pain flare, which was a really good sign. 4th case, 35, and this is where the 4th case, they start to tell us how long they've had post-discontinuation. 35-year-old female, opiate use disorder, sustained remission, does have a history of IV use, tobacco use disorder, and hypothyroidism. She was stabilized on Suboxone 8/2 twice a day for 5 years. After 5 years, wanted to discontinue, transition to XR bupe, specifically Subutex, got 8 shots, 2 300s, 6 100s. At 9 weeks after her last 100 milligram shot, she had some short-lived insomnia, didn't require any intervention, resolved on its own. 6 months after her last shot, bupe and norbupe were still present in her urine. A year post last shot, everything, her UDS was negative, including for bupe and norbupe. And at time of publication, she had a year of post-discontinuation sobriety. So she was doing very well. 5th case, 35-year-old male, opiate use disorder, including IV drug use, tobacco use disorder, cannabis use disorder, and social anxiety. Was on Suboxone 24 milligrams and divided doses, was regularly using fentanyl during the sublingual treatment. Transitioned to Subutex and got 4 shots, 2 300s and 2 100s during this 4-month period. Was the first time during treatment that he was able to abstain from opioid use. But then he said, I don't want any more injections. And for a year and a half, he did really well. The only thing, as a side note, he was taking gabapentin because he continued to have restless legs and interfering with his ability to sleep, but he was taking it as prescribed, doing well. But after a year and a half, he had a 3-day little lapse on fentanyl, got right back into treatment, which was fantastic. Reinducted on bupe at 2 milligrams, was on that for 20 days, then got 3 100 milligram Subutex injections. At the time of publication, he was 6 months post-discontinuation and was sober at that point. Case 6 is a 51-year-old female, opiate use disorder, sustained remission, also cocaine and alcohol use, and in remission, and post-traumatic stress disorder. Was on 16 milligrams of Suboxone for 4 years. After that, wanted to discontinue, did so with 9, 10, 11 months of Sublocade, 300 milligrams for 2 months, and then the 100 milligram regimen, and was able to successfully discontinue. Has more than a year of post-DC sobriety at time of publication. And then the final case was a 36-year-old female, OUD, sustained remission, cannabis use disorder, tobacco use disorder, depression, hepatitis C, was on 8 milligrams of Subutex for 5 years and could successfully weaned with 4 shots to 300, 100, was 10 months post discontinuation at time of publication. All right, I want to turn on the chat feature. Okay, if you were made note during going over, who would you be most comfortable, those 7 cases, with their desire to titrate, to taper? Anybody? I'll just call on you.
I think they all sounded kind of fun, Tony. The one thing I will say is I wonder with these, like, because these are case studies, how many times did they try to do something and it didn't work out so well? You know,
Right, we don't know that. Yeah,
Yeah,
there's just no way to.
these are just the successful ones and how they did it.
Right.
So it's like, were there 5 for every one where it didn't go quite the
Right.
plan?
I'm sure, probably. This one makes me really nervous personally. Like this one is the one that I would be least comfortable with. This one is the one I'd be most comfortable with. Anybody, any other, and the reason for me with the, I mean, this person didn't even have a diagnosis of opioid use disorder, was only prescribed opiates a short amount of time, less than a year. So, and didn't use other illicit substances. So seems pretty low risk, and did well. Although I do wonder, after having a baby, it can be very, that can be a very taxing time. So would want to watch her.
I will say that #1 case where they gave them tramadol and Butrans, I'm pretty sure that was illegal doing the tramadol. So I don't think I would care to do that one.
I've never seen that before.
Yeah, I think that's a violation of Harrison's Narcotic Tax Act, 1914. So.
Toni, are there any standards for methadone tapers that, like when it's recommended that somebody discontinue methadone? It's been around since the 1970s, so we have a lot of cases, well, what is the thinking about methadone and when someone should discontinue?
I didn't do a deep dive on methadone because we don't do methadone here, but generally speaking, the same, like, let me see. These same criteria, this was for methadone and buprenorphine, like the researchers did a lit review on both of discontinuing methadone and buprenorphine. So similar kind of criteria, like looking at their stability, their adherence to treatment, their coping skills, their comorbid mental illness, other prescriptions they may be on, family support, et cetera. The motivation for discontinuing, like why they want to discontinue, the why, just like the why of getting sober, the why of wanting to discontinue. They were similar with both maintenance medications.
Having worked in addictions for 30 years now, I kind of follow the premise that it's the percentage decrease that patients notice. So when you think of receptor occupancy, if you're going from 4 milligrams to 2 milligrams, that's a 50% decrease. If you're going from 16 to 18 or 18 to 16 or 16 to 14, it's a very small percentage, and that's what patients notice. So I recommend trying to decrease by 10 to 20%, in those kind of increments, and then it goes more smoothly.
Yeah, that makes perfect sense. And okay, so looking at the future, hopefully we'll have some robust and data in the next couple years about discontinuation, and maybe have better methods to risk stratify and have discussions with patients on readiness and appropriateness. There's a clinical trial, CTN 100, going on right now. It's a multi-center study. Chestnut Ridge is one of the sites, and it has both a retention and a discontinuation arm. We're just going to look at the discontinuation protocol and what the aims and outcomes are. For the discontinuation, we're looking at patients that have been stable on buprenorphine for at least a year, have the intent. We are no active recruitment to discontinue, no pressure, but have the active intent to discontinue, and haven't been on in the past 12 weeks cocaine, methamphetamine, or non-prescribed benzos, or qualified for alcohol use disorder. And these individuals are randomized to either Suboxone or Brixadi, so sublingual or XR-bup. It's a flexible taper, meaning there's no specific protocol on the percentage or the milligrams for which you decrease week to week or month to month. And the taper is up to 48 weeks with a follow-up period of 24 weeks post-taper. This is kind of the flow sheet for it, and basically it just shows that if people are coming in with on sublingual, they can be randomized to either sublingual bup to titrate or taper, or XR-bup, specifically Suboxone versus Brixadi. If they come in on XR-bup, they stay on XR-bup, and the randomization is just there is an app feature, a discontinuation app. I think it's Connections app, I think it's called. And so you're randomized based on medicine and whether or not you have the application during discontinuation. And then once taper is complete, they are offered and encouraged to take XR naltrexone, i.e. Vivitrol, and then monitored for a minimum of 24 weeks post-taper. And the aims really are to see, like, is XR-bup better than SL-bup for discontinuation? Like, what method is more successful? Does this application have any positive impact or not on discontinuation? And if there are any predictive patient characteristics that can tell us, this is appropriate, or risk stratify during discontinuation discussions. Primary outcome is just binary, yes or no. Did the participant complete discontinuation without relapse? And the definition of and obviously we're talking about opioid relapse, but the definition is no opioid relapse or return to the use of MOUD during taper or 25 weeks post-taper. Relapse is not defined as a one-time use unless it's IV use. Then it is considered relapse. But for non-IV use, if there's a self-report of opioid use on 4 days and greater than 4 days in any 28-day period, or two or more consecutive opioid positive drug tests, that would be a relapse. So any IV use, and then there's some grace or flexibility in the definition of relapse otherwise. And some of the patient character, and there's more than this, and you can clinicaltrials.gov, you can look up this CTN 100 and see all of the criteria that are measured, all the measurement data. But they're looking at historical severity of opioid use disorder, like mild, moderate, severe, IV versus no IV, the length of time they're on MOUD, what kind of recovery capital they have, their distress tolerance. They are doing some genetic sampling in this study. We don't get really the results of that, but the analysis will be done if there's any kind of genetic relationship to capacity to discontinue, psychiatric comorbidities and the impact on successful discontinuation, motivations and expectations for discontinuation, cannabis use status. I can't wait to see what the results are in that, alcohol use status, and many other things like grit. And there's just a bunch of surveys and measurements that are being looked at. So for people that might be around here, by the way, we're done recruiting for the retention arm, but we still are recruiting for the discontinuation arm. So if you're like in commuting proximity to Chestnut Ridge and you have an individual that's really doing well and is stable and has been sober for more than a year and meets that criteria that I mentioned, and we could talk more about that if you would have a patient. But if you think they would be a good participant, we are accepting referrals. So Jeremy Husted, Dr. Husted is the lead MC, and Laura Lander is the site PI. So, I mean, you can reach out to any of us, but those two would be a good contact if you have someone that might fit the bill. And that Interested in hearing any other questions, insight, or experiences with discontinuation on your end?
How long does someone have to be off of Brixadi or Sublocade before you can start Vivitrol?
Depends on how many times they've gotten Brixadi. We had an individual who got 5 months, four or five shots. We waited like 4 months to put him on naltrexone. We gave him one oral dose and made him incredibly ill. So it varies depending on how long somebody takes to metabolize. With Sublocade probably lingers in your system even longer. There's case reports of it staying in your system for up to like 2 years. Katie and I had somebody today intake-wise who they've been off of it for 6 months and they're 5 months and they're still testing positive. What generally we would do is do screens and then do quants on them to see where it's at. But there's some evidence of using microdosing of naltrexone, like getting compounded doses of, say, 1 milligram of naltrexone, and then working up if you want to speed up the process. But it could be a matter of months after their last XR shot. So that's one kind of, in theory, downside. When they were actually coming up with a study protocol, they didn't even want to add naltrexone, but they were almost kind of forced to when they were doing the protocol, for what it's worth. So it might sort of be unnecessary, but it could be on the order of months, basically.
Stop sharing here. Any other questions? Or have you guys had success with people tapering off, leaving the program, discontinuing successfully and going on with their merry life?
Sure.
What characteristics that did you note that contributed to their success?
So I think the biggest risk factor for relapse is psychological issues or, a lot of stressors. So if the person has emotional instability, that can trigger a craving for substances. So I think they do the worst. And then I think patients, I agree with you, a stable life, if you can taper slowly and if they're all uncomfortable, you slow down the taper and the lower the dose you get, the slower you go. I've had a couple cases of patients coming off Sublocade. Most of my cases are tapering, Suboxone or Zubsolv.
The other thing you can play around with is the duration between injections. So if you really want to get clever, okay, so instead of 4 weeks, do like 5 weeks, especially with Sublocade because it's so long, you could even space it out even further. So that'd be another way if you want to try something like this on your own.
I don't know if you saw that, but Lacey is here, and she said that we're recruiting for the study until at least March of 2025. So, and Lacey Kelly is the RN research coordinator, and she put her email in there. Participants, they are remunerated for their time. They're paid for their time. And she can go over like protocols. I think initially they're seen weekly for a month and bi-weekly, and then they go to monthly. So it can be less.
With this continuation phase, they immediately go to monthly.
Oh, that's right. That's
yeah.
right.
So
Yep. So it can be less, requirements for them. There's also more tolerance for things like cannabis use than we might have in other programs. So,
One thing to work on is the science of what indicates a risk of relapse in somebody who's discontinued. What should they look for, as indicators that they may be getting unstable. I know they have some physiologic, like what do you call those? Like Aura ring and those kind of things to look at physiologic measures to see if they indicate a risk of relapse. But we need to get better at that science so we can identify when people are struggling.
all right, well, it's 5 o'clock.